Hello, my friend, and welcome to today's episode. Today's episode is on recurrent miscarriages. Recurrent miscarriages can be very distressing and emotionally challenging experience for couples who are trying to conceive and maintaining a healthy pregnancy. Many PCOS women suffer with this apart from the struggle of getting pregnant, right? So in this episode, we are going to talk about how often miscarriages can happen, why it happens, what are the recommended tests for evaluation? What are the treatment options that you have? And what are the ways to stay supported while you are in your journey to becoming a mother? So, I just want to give you a quick update about what's happening in my life. My life is going great. Well, it's not that great, honestly speaking. Life is 50-50. This is what my coach always says. She believes that life is 50-50, as in this, it is 50% positive and it's 50% negative. And lately, it just feels like it's 80% negative, right? Like, I don't see where is the positive. And that is one of the side effects of um, stopping the emotional eating work, right? Like when you stop emotionally eating, when you no longer use food as a way to cope with your emotions, all the emotions are very raw. And it's like you did all the work to stop eating emotionally because, that food was really harming you. But we also need to constantly do the work to support ourselves emotionally. So that's like a constant journey for me, constantly like finding people who can support me emotionally, my coaches, my therapists, um, anywhere I can get support, I would get it. Right. At the same time, doing the homework which is required, all of that. And even when you're not doing anything, the best way to do it is like just sit with it. Like you don't really have to get much support because the work is basically like, to just like let it be. The more you just let it be, it will pass. So that's what is happening with me. Life is up and down constantly. And especially with my perimenopause coming, I'm just feeling all the emotions. And I want to say that it maybe is the perimenopause. I hope it is the perimenopause because that should end soon. Anyway, wish me luck for that. And let's get started with the podcast today. So, today's podcast is based on the latest RCOG guideline on recurrent pregnancy loss, which was released in June of 2023. Now, I also have another podcast on miscarriages. And this one is more of that podcast is more of the what are the options of treatment when when a miscarriage has already happened, like the medical management, the conservative management, the surgical management. So that episode will deal with that. But this episode is specifically about the causes and what are the tests and ways to prevent it and what are the treatments available. So a miscarriage is basically defined as a spontaneous loss of pregnancy before baby reaches viability, as in before the baby can survive outside. So in the past, baby would survive after 34 weeks. The baby will survive easily. But now we have high tech and ICU facilities, even in advanced countries. Like advanced countries might be able to support the babies from 23 weeks, 24 weeks onwards. In developing countries, the NICU facilities can support somewhere like from 28 weeks onwards. So until that time, we label a pregnancy which needs support 24 weeks. The term, therefore, includes all pregnancy losses from the time of conception until 24 weeks of gestation of pregnancy. So there are two main type of miscarriages. Now, in the previous episode, I talked about evitable miscarriage, inevitable miscarriage, miscarriage, complete miscarriage. Those are the other classification. These ones are like the causes type, right? So there is a sporadic miscarriage, and then there is a recurrent miscarriage or recurrent pregnancy loss. So the sporadic means just, it's a medical term. Sporadic means just like happens. Like there is no reason why it happens. It just happens. So it generally happens due to genetic problems in the baby. Like there is something wrong in the gene structure of the baby. It could be a point mutation. And that baby will not be able to survive because of that point mutation. So that is a sporadic miscarriage. Whereas, and that can happen to almost 15 to 20% of women. So if there are like, if I'm in an urgent care or an emergency room for just pregnant women, and there are 10 pregnant women sitting outside, one or two would be having miscarriages. It's that common, right? So that incidence increases with age, and almost the risk of you having that kind of miscarriage is almost 50% by the time you reach 45. Like every pregnancy, half of the time will miscarry as the age increases. Whereas recurrent pregnancy loss or recurrent miscarriages are referred to the occurrence of 3 or more first trimester miscarriages. Like first trimester means up to 13, 14 weeks. So if you're having 3 miscarriages, which are less than 13 weeks of pregnancy, that's when you are labeled as recurrent miscarriage. Now, this is important because the investigations differ. The type of evaluations doctors are going to do is going to be different because like in some countries there is insurance, in some countries the country provides healthcare, and in some countries you can just buy, you can just pay for the investigation and do it, right? Like in India we don't have so much insurance, so we could just like, doctor recommends test, if the patient has money she can do it. Whereas in UAE we have insurance. America, there is insurance, so the insurance has to approve these investigations and only then we can do it. Whereas in UK there is NHS, which is like the government is paying for everything. So there again they have very strict policies. It's the taxpayers money, so they need to use it in a very conservative way. So only things which are justified need to be done. Now suppose you are in a place like India where the doctors might just like keep doing with one miscarriage all the tests. They're really expensive tests. So if they were cheap tests, no problem, we can do it. But they're really expensive. And also if it turns out to be positive, you might get stuck with treatment which can be risky treatment, right? So that's why it's important to justify, for doctors to justify the reasons why they want to do that sort of investigations for you. So world over, everyone agreed recurrent miscarriage is when you have 3 miscarriages or like 1 second trimester miscarriage. So normally, as I said, sporadic miscarriages, which just happen out of nowhere, the genetic ones, that can be like 15 to 20%, but recurrent miscarriage actually happens only 1% of the women. So there are 100 women trying to get pregnant, only one would actually keep on miscarrying. Not everyone will. So the chances of someone to have recurrent, like suppose if you had 1 miscarriage, you might be like, what if my next pregnancy is also a miscarriage? And what if my third pregnancy is also a miscarriage? Oh my God. That might not happen because it's not that common. It's rare. Okay. So only 1% of women experience that. And also second trimester miscarriages, wherein you lose the baby from after 14 weeks to 24 weeks, anywhere where the baby is actually like this big and you lose the baby. That is also like 1% risk. Right. So that is also very rare, not that common. So why these miscarriages happen? Number one and the most important cause of miscarriages is maternal age, as in the mother's age. The data indicates that as the mother gets older, the risk of miscarriages increase because the quality of eggs that we are making, the maturation, that is depleting. So woman who is like around 40 years of age, the chances of she having miscarriages are increased almost 7 times. Whereas those who are having babies at 45, the chances of them miscarrying are almost 30 times higher. So much compared to someone who is in her 20s or 30s, right? So if you are in your 20s and 30s, don't worry, chances of you miscarrying are very low. So that you can just relax. If you are in that age group of like 35 and about to 40, there is a risk, but I will tell you what to do with that. After 45 also is very high risk, but I will tell you what to do. Now, this is about mother's age, but the baby is not just the mother, right? It's also the father. So the study which they did in this paper, they found out there was no hard correlation of a father's age, right? Like the partner's age doesn't matter, doesn't really produce miscarriage, because the partner will just give the sperm. It's the mother who has to hold the baby, right? So mother's age, mother's ability to hold the baby will be a predominant factor in miscarriage. Now, the next factor which can increase, which which is an important risk factor for miscarriages, previous miscarriages. Normally, as I said, every pregnancy, every woman would have a risk of miscarriage of around 15 to 20%. As the number of miscarriages increase, like suppose you have one, there is a risk that, maybe you might have another one. It's like around 1 to 4% risk. If you have two miscarriages, the chances of you having a risk of miscarriage is, the third one miscarrying would be around 4 to 9%. So the risk keeps increasing the number of miscarriages you had in the past. The next strong determinant of miscarriages is bleeding disorders or clotting disorders, blood clotting disorders, which is called as thrombophilias. And we don't check for these investigations if you have one miscarriage or even two miscarriages. These are done only after you have three miscarriages, because these are specialized tests. They're expensive tests, so insurance doesn't approve so easily. We need to justify for it. You need to be eligible for it. Even NHS will not approve of it. And if you are someone who can just pay and get it done, again, as I said, it's expensive. So if you have the money, your doctor might do it. But always remember that these tests need to be done at least 6 weeks after pregnancy, when all the pregnancy changes have gone, and you need to do them when you're not pregnant, right? So again, you need to be in touch with your doctors if you're undergoing a miscarriage. We can't just do all the blood tests for you immediately when you're miscarrying, because it doesn't make sense. They are all funny when we do it in the blood in the pregnancy, right? So these are lupus anticoagulants and anticardiolipin. Now, the next predeterminant of miscarriage is alcohol. Like I'm talking about which are the most common, strongest risk factors. The next after the clotting disorders is alcohol. It was shown that alcohol consumption during pregnancy is associated with increased risk of miscarriage, and it's advisable for women to avoid alcohol or limit it during pregnancy. This is because alcohol consumption is not so common in Asian communities, but in European places, this is very common. So they have I think they allow 1 unit or something. I'm not so sure about it because I've not practiced in these countries. But overall, if you are consuming alcohol on a regular basis, that needs to be limited if you're experiencing miscarriages. There is strong evidence which shows that. The next one is congenital uterus anomalies, as in you're born with defects in the uterus, where you have two uteruses, or there is a septum in the uterus, or you have one uterus but then two cervix, or two vaginas, or some sort of defect in the uterus. Like you have a uterus but there is a defect. It's again very rare. This can cause miscarriages, especially if you have a septate and there is a surgery to prevent it. So it can increase the risk of miscarriages. Or also sometimes some patients might have fibroids, which can increase miscarriage risk, and they can be corrected with surgery. So they need to be investigated for. The next one is endocrine factors, which is basically your hormones, specifically thyroid autoantibodies. They have seen that there is some evidence that they can produce miscarriages. So that can increase your risk of miscarriage. And lastly, these all the factors which I talked about, which is basically the age, maternal age, mother's age, previous miscarriages, blood clotting disorders, alcohol, uterus defects, genetic defects in the parents. That is another one. I forgot to mention that there can be like small genetic defects which can be passed over if both of you have it. And the endocrine or the thyroid problems. those have slightly higher risk of miscarriages. And then the next ones, which I'm going to talk, they slightly increase your risk of miscarriage, not strongly. And they are smoking, caffeine intake, obesity or being underweight. There's not strong evidence, but like it doesn't increase your risk so much higher, but there is strong evidence which says that it increases the risk slightly. Like there is a significant risk which women who smoke, who are having caffeine, excessive caffeine, who are overweight or who are underweight are going to experience more miscarriages than the normal population. Those who are not smoking, or those who are not having so much coffee, or those who are in normal body weight, right? So there is strong evidence to support to correct those factors. And lastly, there is very limited data supporting evidence of environmental chemical factors and chemical exposures, like all your endocrine disruptors that we see on social media, or the dietary intake of certain things, right? Like there is no strong evidence because these are so insidious. Like not many people are able to gather data, to collect data around these. So there is no strong evidence yet that is found which supports that they cause direct miscarriage, right? So those were the causes, why it happens, why the miscarriages happen. The next one is like, what are the recommended tests that we can do to evaluate for these causes? So clinicians, what they recommend is, even in advanced countries, like suppose insurance based countries, we can push for it, we can discreetly push for the investigations. Maybe the insurance might cover it if they suspect that it is not a genetic, not a sporadic miscarriage, right? There is like probably a blood clotting disorder or a thyroid problem or something that the doctor is suspecting, we can push for it. But of course, those who are cash paying, they can easily get those things done. But investigations are recommended, like discreetly after 2 miscarriages and definitely after 3 miscarriages. I know it's very disheartening to go through, to wait for a third miscarriage to be evaluated completely. But if you have the money, tell the doctor that I have the money. Can you please test for it? They will be happy to do it for you, because someone needs to pay for those tests, right? So if the insurance is not paying, if the country is not paying, can you pay it? Like if you are in a hospital where they don't allow outside investigations, no, it has to come through the justification that there's nothing much you can do. Maybe you should go to a private doctor who might do it for you, right? So after 3 miscarriages, the whole investigation will start. They will check if you have those blood clotting disorders before you get pregnant again, or after you have miscarried 6 weeks after that. If you have second trimester miscarriages, they will again check for some inherited, as in like genetic clotting disorders. Then a DNA study for the baby, as in when the miscarriage happens, the pregnancy, the doctors can send that test for DNA testing to see if there is something wrong with this pregnancy. Okay, and this is a specific test, again, a very expensive test. If it's a second trimester miscarriage, and most insurance companies will approve of it. If you have had 3 miscarriages in the past, they will approve of it. But again, because this pregnancy comes out, it's very small, they might not be able to culture the cells. So sometimes there's a failed culture, or they don't gather much data after doing this expensive test as well. That just happens. And when that happens, we can do genetic testing, the coupled DNA testing, as in both you and your partner can be tested for your DNA. Where if the pregnancy showed, like suppose if the doctor managed to get some DNA testing and it showed unbalanced structural chromosomal abnormalities as specific genetic problems, then they can check for the same things in you and your partner. Or suppose if the doctor did not find anything in the pregnancy tissue, still they can check for you and your partner both for the genetic problems. Now, these tests are again not done by gynecologists, they are done by geneticists. So there is another specialist who will be doing those tests, because they know exactly, like you need to be referred to a geneticist who will take a detailed history of whatever you're going through, and then they will try to search for certain gene defects that you might carry. because we have so many genes, like millions, right? So we need to know exactly which one we are looking for, and only a geneticist can know that. Now, recurrent pregnancy loss women should get a 3D ultrasound to look at the shape of the uterus to see if there are any anomalies. So you become a candidate for that. And also, you can be offered thyroid checking and the antibody check. Now, lastly, what are the treatment options when it comes to recurrent miscarriages? Now, the treatment depends on the identified cause, if any. So suppose if there is any anomaly in the uterus, then they can, if that can be corrected, like this a big fibroid is just pressing on the cavity, they might consider removing that fibroid. Or if there's a septum, they can resect the septum. If there is uterus looks normal, they might not be able to do much, right? The next one, if there is, if you're smoking, cut down smoking completely. If you are drinking alcohol, stop it completely. If you want to have your baby, just stop it. If you're drinking caffeine and you want to limit it to 200, I would just suggest stop it. I know a lot of women who have done that. You can do it too. Weight loss is recommended, especially if you're overweight or underweight. So if you're overweight, if your BMI is more than 25, work on bringing it below 25. Or if your BMI is less than 19, we need to bring it up to 19. And these are very emotional problems. These are not something which is can be just like corrected overnight, right? You need emotional support to do these things, right? So correcting the weight could be one of them. Now, suppose if there is an identified cause of antiphospholipid syndrome, that is your blood clotting disorders, then when you get pregnant, the doctor can offer you aspirin, the baby aspirin, low dose one, and a blood thinner called heparin. It's an injection which you will have to take every day. It's offered if you have positive tests. If you find out that you have this problem, only then it is offered, right? The moment you get pregnant, the moment you do a urine pregnancy test, the doctor can offer you as early as possible, and it is continued at least till 34 weeks. Now, the blood thinner, aspirin, not so much of a problem, is well tolerated, but the blood thinner can have potential risks associated because it's a blood thinner. And if you start bleeding, you will not stop bleeding. So, and plus it's an injection, which you have to take every day. So you'll have to balance out the risk and benefits. The doctor will have to counsel you. So it's a long, lengthy, high risk treatment, right? Now, many doctors will just start this treatment for unexplained recurrent pregnancy loss. Not recommended. If your reports came normal, you don't have to go through this injections. Don't be under the illusion that the treatment is with the injection. Still, the doctors everywhere will still give you this because they don't have much to give. Some doctors were recommending thyroid supplements even when your thyroid report was normal. It's not recommended. As per the study, if your TSH is above 4, if it's abnormal, only then we need to correct your thyroid. Otherwise, it's not recommended. Now, progesterone supplementation. There is lot of progesterone which is given. Doctors will give you a progesterone, very painful oil injection every week, sometimes twice a week. They'll give you duphaston, they'll give you vaginal progesterone. You don't need so much. There is not much hard evidence for any of this, so you don't really have to take it everything, but the doctor will actually tell you, this is all I can give it, take it. And if you don't take it, if the miscarriage happens, it's because of you. Don't fall into that trap, please. If your doctors are using that language for you, change your doctor because that doctor is really trying his best or her best, but there is really no evidence supporting it. I don't want my patients to take those really painful injections which have no evidence, right, that it works. You can just use a vaginal suppository or a rectal progesterone. You can put that backside as well, 2 times a day. That's good enough. And that is also, the evidence says that you need to take it only when you're bleeding and you're not miscarrying. So the bleeding has started in pregnancy, only then it's indicated. But most doctors will start without bleeding because you want to just give you so that you don't miscarry, right? And it's given till 16 weeks, but many doctors will keep it until 34 weeks. So this is all very preventive treatment that many doctors will do. Many insurances might approve, and since they approve, they just keep on carrying on taking. There is no hard evidence supporting of all of this. Now, last but not the least, we need emotional support. Pregnancy loss is a very traumatic experience. So, dealing with recurrent miscarriages can be emotionally devastating. And many couples find it helpful to seek emotional support from counselors, support groups, trusted friends, and family members. And it's important to address the emotional aspect alongside the medical aspect. So, most women have no dedicated support groups. Even the hospitals I have worked with, they would have a recurrent pregnancy loss clinic, but that doctor is not trained in emotional support. I, being a coach, I was also not able to support these women because I'm not a therapist. Because therapist is someone who's going to help you with the trauma which has happened, which will help you heal that trauma. A doctor is not trained for that. Let's be honest. Facebook groups, they're everywhere. It's just a group of women who are together sharing each other's experiences. The moderators of those groups can help you out, but they don't always, depending on if some groups are just too busy, they might not be able to do anything. So people will just come and post, and you might not get the support that you need. I mean, you can hang out over there. Some women might get some support, some might just get gaslit, and they might get triggered and feel even worse after being in the Facebook group. So I would really recommend, if you are someone with recurrent pregnancy loss, is to get a therapist to resolve the emotional trauma that you experience with every pregnancy loss, and also getting a life coach, because a life coach can help you try again, as the only way we can get to our baby is when we keep trying. We keep trying while changing our approach each time until we get to our goal. Now, they say, right, like it takes a village to raise a child. And when it comes to recurrent pregnancy losses, miscarriages, we do need a doctor. We do need a geneticist sometimes to check for the genetic things. We do need a therapist. We do need a life coach, and we do need a supportive family members. So if you are someone who is struggling with recurrent pregnancy loss, I really offer you to come on a clarity call with me, because I'm not a therapist, but I am a life coach who's also a physician, who understands what you have to do to keep trying again while you are going through the trauma. And if I see that you have a lot of trauma which is coming up constantly while you're trying, I can help you, tell you that you need to go to a therapist. But if something can be solved with just life coaching and just talking, please consider coming on coaching. All right, my friend, that's it for today. I will see you next time. Bye bye.